Good evening.
Good evening, sir.
Good evening. Can you start? Am I audible?
Yes, sir. Yes, sir.
Okay. So we can start on any point. So if you have any some case or anything particular you want to discuss, please let me know.
Yes, sir. I have, sir, two questions. One is whenever there is a increased androgen level or progesterone level, you are saying that we should give corticosteroid. So how it is decreasing the level of progesterone and androgen action of
Sorry, can you
corticosteroid?
repeat the question?
Yes, sir. Sir, you said whenever the androgen level is high or progesterone is high during stimulation, we should add corticosteroid. So, how it is acting? This is my one question, sir.
Okay. So by suppressing the adrenal gland,
Okay.
because the progesterone, there are two sources of progesterone. One is ovarian, and another is androgen. So in early follicular phase, it is believed that if the progesterone level is elevated, it is either because of the rescue of the corpus luteum of the previous cycle, or it is most of the time adrenal origin. So we don't know contribution of adrenal origin progesterone. So if you give then the level is suppressed, especially in early follicular phase. It's been observed that even if you suppress early follicular progesterone, which is already raised, and if you suppress with the steroid and you continue or you start stimulation, ultimately the progesterone level on the day of trigger is always high. So overall, there is a early follicular rise of progesterone, you're not able to transfer the embryos fresh because most of the time progesterone is elevated. But still, it is okay because consistently higher progesterone, uh, which is not advisable, especially right from the early follicular. So that this is about the progesterone and the androgens. Androgens are multiple source and adrenal is one of the source. So by giving glucocorticoids, you are suppressing adrenal origin of the hormone, especially when DHEA is higher, then it is quite effective. But even if the DHEA is not high, overall the androgens are high, it has got some effect on in the androgen. So basically, it acts on adrenal, suppressing the adrenal gland.
Okay, sir. Sir, one other query. Whenever there is resistant endometrium, that it is very thin and not growing very well, what is your experience or giving long agonist suppression, ultra long agonist suppression, and then making endometrium or after HRT? Suppose
Uh,
endometrium is not growing. Yes, sir.
See, suppose endometrium is growing with simple non-down regulated HRT, there are two options. Either you have to go for a stimulated cycle with the logic that natural project created from the follicle might act better way endometrial estrogen receptor and helps in better proliferation of the endometrium. Second option is you down-regulate completely the body. So whatever abnormal hormones are there, progesterone, maybe progesterone, maybe estrogen, maybe FSH, LH, whatever, all are suppressed. And we all know that the androgens are uh, uh, antagonizing the action of estrogen on the endometrium. So by suppressing all hormones, uh, if you start fresh proliferation with the estradiol, then proliferation is better. Now, if you ask me what evidence, the evidence there is evidence that it may the down-regulated cycle gives better endometrium. And if you ask my experience is mixed. But there is no option when there is a associated adenomyosis or endometriosis. In such case, you should downregulate the cycle for 2 months and then add estrogen. So it is not a universal law or experience, you can say, from if you ask my experience, that okay, if I downregulate the cycle, agonist cycle, then I am going to get much better endometrium. No, it is not completely true. It is from patient to patient. Now, a lot of other people are also there. So kindly participate. If you have any question, please keep asking. You can raise your hand so that I can tell you to unmute and you can initiate the discussion. Because I do not want discussion to be by the limited people. I want you all to participate. And if you want to contribute anything, you are most welcome. If you are differing in the opinion, you are most welcome. If your experience is different, you are most welcome. Yes, Dr. Nina, do you have any other question?
Yes, sir. I want to add one thing that
Yes.
as you have said that 150 international unit of SCG, so very easy to give. I have find one way that there is a zero point 0.5 ml of recombinant SCG. So first, what I am doing, I am taking 10 ml syringe, adding 9.5 ml of distilled water or normal saline, and adding zero point 0.5 ml of SCG and connecting it tri-way with that. And there is
That
a
is what
one.
yeah, that is Dr. Nina. In one of the talk, I have already suggested this way.
Okay,
You are
okay,
doing it
sir.
very correctly.
Yes, sir. Yes, sir.
That's absolutely valid way. But the only problem is this SCG, this reconstituted, you should use within 4 days only.
Yes, sir.
Hmm? Dr. Surjit, Dr. Surjit, please,
Yes, sir.
please ask your question. डॉक्टर सुरजीत आपने हैंड रेज किया था ना
Sir, I'm audible?
यस ऑडिबल डॉक्टर भावना प्लीज
Sir, now my question is, sir.
डॉक्टर
Hello?
सुरजीत इज आस्किंग डॉक्टर सुरजीत इज
Hi.
आस्किंग राइट
Hi. Sir,
यस
my
बोलिए
question is that when we do the ovulation induction extended protocol with the letrozole in PCOD, so my question is how it acts when there is a high LH levels and androgens also high. In that cases, I want to know about the ovulation induction.
Okay. So, what is your question? Your question is how letrozole, extended letrozole, uh, whether it is first of all, what is uh, uh, the aim of using oral drug is to facilitate the recruitment of the follicle. Recruitment of the follicle. For recruiting the follicle, you need to increase the FSH or increase sensitivity somehow. So when you are using letrozole primarily at the initial of the cycle uh, causes increases the sensitivity of the follicle towards FSH, and because of the increased androgenization in the follicle, prevention of the conversion of androgen into estrogen. So local collection of the androgen is there, and because of that, there is increased follicle sensitivity towards FSH, and there is some FSH which is secreted from the pituitary at the initiation of the cycle. That is a natural phenomena. So this FSH can act in a better way in such type of the follicle, and as follicle advances, uh, uh, the estrogen which is likely to be synthesized is not synthesized enough, and still there is more aggregation of the androgen. So that negative feedback normally is given by the increased level of the estradiol secreted from the follicle is not there. So this pituitary keep secreting FSH, and that keeps helping the follicle to grow more. Once the follicle grow beyond 10 millimeters, it acquires FSH as well as the LH receptor, and rest of the follicles uh, they start regressing. So now, if even if the FSH is uh, not secreted in enough amount, even if the smallest amount of LH, which is there, basal LH, that is able to conduct, it is able to continue the growth of the follicle, and this is how the monofollicular development happens. And the rest of the follicles, they are not acquire their receptors, adequate FSH receptor, so they are suppressed. Now, talking about extended letrozole protocol. So in the extended letrozole protocol, still if you continue with the letrozole will keep uh, inhibiting the conversion of androgen to the estrogen, and it will so that negative sense of negative feedback will continue a couple of days more, and that will help in uh, bringing out more FSH, and at some point of time the FSH threshold of some of the follicles is broken, and once that FSH threshold is broken, the follicles start recruiting and further growth. Uh, uh, the extended letrozole protocol has got, I have discussed a couple of times before. Once the follicle is recruited and is growing follicle more than 10 millimeter, then if you continue with the letrozole exclusively, gonadotropin, it forms the cyst. That is one thing. And second thing, the best result of letrozole you get when you add gonadotropin along with the letrozole. That gives the best follicular recruitment, because you are not only dependent on native FSH, but you are adding a gonadotropin from the external source, and follicles are already sensitized uh, for FSH. That gives a better action.
So, sir, we should give for 5 days, then followed by the gonadotropin?
Ideally, that's my standard practice. So I, rather than 5 days, I wait, because I have discussed and I have experienced that following gonadotropin, the follicular recruitment and initial growth is slow. Even if you use 2.5 milligram, uh, if you start with the 2.5 milligram, and if you start with the 5 milligram, that is 2.51 BD, sometimes follicle recruitment is fast, but the endometrium is not able to cope up. So endometrium remains thin, and the follicle is overgrown. So you find difficulty in the synchronization of the endometrium and follicle. So after 7 days, if you do not find any recruitment of the follicle, and if the patient is non-affording, then you can step up the letrozole. And if the patient is affording, I always prefer to add gonadotropin.
So, sir, you prefer 2.5 milligram?
Yes, I always prefer 2.5 milligram.
Thank you, sir.
Dr. Sandesh? Dr. Sandesh, please.
Yes, sir. Yes, sir. Sir, now you said 2.5 milligram. This is for IUI, you must have said, correct? It?
For non-IVF cycle, whatever we are starting for time intercourse or IUI cycle.
No, but suppose if I want to give it in a low responder or poor responder, 2.5 milligram for 10 days along with gonadotropin. So is it okay to give for 10 days letrozole from
You're talking about IUI cycle?
No, IVF. Sir.
Okay, you're talking about IVF cycle.
Yes, sir.
Yes. So if the letrozole is covered with gonadotropin, and obviously if it is an IVF cycle, definitely we cannot rely on only letrozole. So if you cover it with the gonadotropin, and if you continue with the all 10 days, what has been observed that if you add letrozole, it reduces the requirement of the gonadotropin little bit. That is the only if you add letrozole. And if you are thinking about the fresh transfer, obviously letrozole has got positive effect in the form of the genes, the upregulation of the certain genes, receptor genes, which are responsible for the implantation.
Okay.
But yes, you can.
Yeah. So in a low responder, if suppose the patient's AMH is around 1.3, 1.4, so can I start only with HMG, or I can add HMG with FSH, like 375 plus 75 FSH or something in a normal BMI patient?
So you want to ask in poor responder where the LH activity is required to be added. In other way. See, please try to understand that if you are using HMG, you think that you are giving enough of LH activity. No, it is not true. Please, ये concept दिमाग में से आप निकाल दीजिए. There is a difference between FSH and HMG as far as the follicle recruitment and growth of the. If you really want to add LH activity, which is required in Poseidon group 1, 2, and 4. Now, Poseidon group 1 is unexpected. So in the same cycle, you can you always get idea after finishing the cycle. Go, okay, C responded in very poor way in spite of younger age and adequate ovarian reserve. But Poseidon group, where the age is the only problem, the ovarian reserve is adequate, and Poseidon group 4, where advanced age and so these are the three groups. LH activity plays an important role, and so this three group requires LH activity. So I always recommend, if you really if you want to add LH activity, you should either use recombinant LH or a small dose of SCG to be used. And there is another paper, and which matches with our experience, that whenever there is the age of the patient is more than 34 years, in fact, the SCG works better than recombinant LH. You can imagine now. There is a third paper which studied that the follicular maturation, implantation, clinical pregnancy rate, ongoing pregnancy rate, everything is when mid-follicular SCG level is higher, means between 5 and 9. So this is only attainable if you add recombinant SCG or RSCG or urinary SCG right from the beginning of the cycle, not in the mid-follicular phase of the cycle. So now the question will come, is there any rationale of combining recombinant FSH and HMG or FSH and HMG in standard stimulation of the cycle? May it be normal responder, may it be poor responder. According to me, there is no rationale. There is no rationale. We are using HMG just to the cost. If preference is to be given, then it should be HMG only, provided you are happy or you are sure with the efficacy of the molecule which you are using. So if you are happy with your gonadotropin HMG, without thinking twice, you can use in poor responder, you can use in normal responder, you can use in hyper responder also, without worrying about the LH activity. But patient is advanced age, I would recommend to add small dose of SCG along with the, even if you are using HMG, you can add small dose of SCG towards LH activity. Now, then you will ask, then what do I use? I always start with, most of the time, I start with the recombinant FSH. If the LH activity is not warranted right from the beginning, means the patient is not elderly. So I always recombinant FSH. And once the follicle crosses 12 millimeter from the day we start antagonist, I change to HMG for no other advantage, but I want to cut down the cost, because for recruitment of the follicle, I want a very reliable molecule. And further, even it has been noticed that even after stimulation day 5, even if you stop gonadotropin, follicle will continue growing for next 4 days, and estrogen will even keep rising for 2 more days. So even if you give less efficacious gonadotropin or little less reduced dose of gonadotropin, the follicle output rate and maturation rate is unaffected. So, and simultaneously you cut down the cost. So that is only rational of converting from RFSH to HMG. I am really surprised. A lot of people, they are right from the beginning with the RFSH and HMG. I do not know why they are doing so, because in HMG the true LH activity is very minimal in HMG. So whatever HMG, whatever LH activity is there, it is added by the SCG, which is just 9 units of SCG, which is equivalent to 75 units activity. So if you are using 50, it is 18 units. If you are using 300, it is 36 units of SCG. That's all. And if you really want to provide a robust LH activity, it should be in the range of 125, 150 units of SCG. I hope you got your answer. Or
Yes,
you want to ask anything else?
Yeah. Now, suppose if I want to start in a low responder, I can start with RFSH with HMG 150.
Please specify. Posidone 2, 3, or 4.
Okay. Sir, in a Posidone 1 and 2, where I get not a good response, even after giving HMG or even Menopur also. So that time I can use RFSH along with this thing, HCG, sir, small dose.
For sure, boss. For sure. In
Okay.
cases, may it be, see, if you make a habit of continuing stimulation with RFSH added with of SCG, irrespective of the responder, may it be normal responder, may it be poor responder, may it be a hyper responder, there is no difference. You should not worry. You should not worry.
Okay. So
Because
this.
the LH activity provided by the this is very nominal. See, suppose even if PCOS, if you use, I think I had presented one case. Even if she was PCOS, I had it RSCG. A couple of days back, go through the case sheet. I had used as RSCG. So does not make difference. You should not worry.
Okay, so this Ovitril or whatever recombinant which I use it. So if I if I want to make up to 125, 150 units, so how to make it that thing, sir? And I can use the same Ovitril for the in 10
5 days.
days, or I have to change it.
See, there is only at one place to study from Egypt, Dr. Abulgar. He mentioned that this type of reconstituted SCG can be used for 4 to 5 days. So I recommend you have 2 ampoules rather than 1 ampule.
Okay, so how to reconstitute, sir, that thing if I want to make it?
That's a Dr. Sindh, absolutely a mathematics, because Ovitril or RSCG which you are using is 250 microgram, which is equivalent to 6,000 of SCG activity.
Yes, sir.
So you can dilute with the normal saline, and you can calculate the per ml what is the unit, and then take that reconstituted solution in the insulin syringe, and you can calculate that one unit of insulin syringe is equivalent to how many units of SCG, and accordingly you can give.
Okay, sir. Thank you, sir. So this I can use it for the normal, poor, and even for the PCOS,
Anything.
correct, sir?
Yes, yes.
And then I continue with RFSH with this, and then I can switch over to the HMG after 5 days.
See, at present, I am conducting the trial in my patient, 2 patients, where I have added urinary SCG to the biosimilar FSH. I use Bryogan, Zydus,
Yes,
and
yes.
I have urinary SCG diluted in the injection already, because it is a cartridge system. So where in cartridge I added urinary SCG, and I have started. I think today evening I will come to know the response of the first. Today is, I think, stimulation day 10 probably. So I will update you. But just for my knowledge, I measure the serum SCG level, beta SCG. I found very low. So I don't know whether it has affected and how the beta SCG level is 1 or 1.4 it was, which I was expecting it to be more than 5, but which did not happen. So I'm waiting for a couple of more cases, and then I will come to know what is what.
Yeah, sir. Another thing is in PCOS, if I give a RFSH along with SCG, now when I give a trigger, so usually 1 or 2 patients I got empty follicle syndrome. So I have started using 1,500 means half Ovitril after doing a E2 level on the day of trigger. If it is less than 3,000, I usually give a 2 decapeptile along with 1/2 cc of half 125 microgram of this thing, Ovitril. So now if I give a SCG right from the beginning in a PCOS patient, so is it necessary to give then SCG, because I am adding some SCG?
See, Dr. Sandhu, I'm telling you, I said that you can definitely use this SCG in PCOS, especially if the patient is advanced age. I would not to use in very young patient, because in advanced age patient, the LH receptor response and HPO axis is not working efficiently. So we where little extra LH activity in the form of SC would probably help in a way. In younger patients, that is not a case. So by mistake, if you use, it does not cause any harm, but better to avoid in very young patients. So don't you in young patient you use RFS, what is it called? Or HMG, whatever. Because for that matter, both.
Okay, but then sir, trigger then if I have to
Now
go with
coming
the
to trigger. In PCOS, getting empty follicle in PCOS, getting less number of mature oocytes are very common, very common. Because we all know the PCOS egg qualities are not at par with the normal type of patient, for sure. But why we not suffer? Because of the lot of number of eggs. So some or other eggs will form a good embryo. So the cumulative pregnancy of one stimulation is not affected. You agree for that?
yes sir.
Yeah. So now, whenever you are getting uh, uh, an inadequate response following your agonist trigger, I would, rather than jumping to adding SCG, because probably you have not seen the OHSS, or I do not know what is your
No,
experience about
no,
dealing with the OHSS.
I have not seen single patient, sir.
I have seen, and I have treated also abdominal paracentesis. I have done transvaginal aspiration of the ascites.
Oh,
It's a really complication which requires. So unnecessary SCG should not be used in PCOS. You have to think about other things rather than adding SCG in PCOS cases, because there are two way of predicting OSSS in PCOS. One is peak E2 level, and another is number of the follicles which are more than 10 to 12 millimeter on the day of trigger, right? So if on the according to study, if the you are rightly saying that two on the day of trigger is less than 3,000, you can afford to add SCG. I totally agree with you. But again, you are relying on the laboratory, which many times false reading. So the better way of predicting or preventing OHSS is rely more on the number of the follicles which are more than 10 to 12 millimeter on the day of trigger. If they are more than 18, never add SCG, never.
yes
Okay.
sir.
Okay. Now coming to, suppose this has happened and you do not want to add SCG. So what are the possible reason? One, I said that the receptor, which the LH activity which is given with your trigger may not be adequate, and probably those follicles requires prolonged LH action. That is one thing, possibility. Second possibility, the basal LH level or the LH level on the day of trigger was quite less, maybe less than zero point 0.5 or something like that. So in that case, this is going to happen, and this only happens. This happens to the case where prolonged OC pills has been given to the patient, and which is likely, especially in donor. This is second thing. So next time, what I will do, I will give some micronutrients for 1 to 2 months. Definitely, I will put her on metformin for 1 to 2 months. I will hold the stimulation for 2 months. I will give vitamin D. So whatever other things which I, before jumping to the stimulation, whatever I can do to improvise the follicular environment, I will do. And then I will start a stimulation. Before starting stimulation, I will measure serum LH. If the LH level is less than zero point 0.5, then mentally I will be ready. Okay, this patient is going to give me trouble, and I will have to monitor this patient more frequently after treatments. Then I will again measure serum LH level before trigger, on the day of trigger. Again, if it is less than 0.5, for sure, I'm going to have a problem. And in that case, I will not be hesitant to add a small SCG with the calculated risk, because both the levels are less. Then I will not. At the starting of the stimulation and on the day of trigger, if the LH level is less, then surely the agonist trigger is going to fail. So in this case, I will use SCG trigger. But suppose the LH level is more than 0.5, say it is 1.8, and still, if you want to make sure that everything is falling in place, the best criteria of efficacy of the trigger is judged by progesterone level. Because if the progesterone level is adequate for trigger, itself suggests the luteinization and action of the adequate LH surge, which has followed the agonist trigger. So in such case, the always measure after 8 hours after agonist trigger, measure progesterone level and LH after 8 hours, measure after another 6 hours. Because what happens after 8 hours, we measure the LH is at least should be more than 15. Most of the time, it is in the range of 50, or maybe sometime more than 50. But anyhow, it should be more than 15. And progesterone level should be approximately in the range of 3 nanogram. But if you measure little late, there is time downfall of the LH. So LH may be around 15, but the progesterone is between 3 and 6, 3 more than 3. So that also is sufficient. So if you measure the hormones repeatedly, then before trigger, you can understand that if the catastrophe is going to occur or not. Now suppose the LH level in all reading is less than 15 and progesterone level is also less than 3. So in such patient post-trigger, you should not be hesitant. Give you to rescue the cycle, you have to give a small dose of SCG as a trigger. Now, what is the triggering dose of the SCG? In dose finding study, they say that if the patient is hyper responder, you can give SCG 3000 unit. If you give anything less than 3000, chances of initiating meiotic meiosis from M1 to M2 quite reduced, maybe less than 50%. But if you use 3000, the chances are somewhere around 75%. And if you use 5000, it is somewhere around 85%. If you use 10,000, it is more than 95%. So this is how the meiotic division is initiated following your SCG trigger. So, but you can afford to give 3000, and if the patient was obese, then you have to increase the dose of to 5000, because in obese patient you require higher dose of SCG trigger. So this is how you should go. But still, after doing all exercise, still ultimately the basic quality of the oocyte receptors cannot be studied adequately, and it is dissatisfaction in the form of lesser follicle output rate, less number of M2 keep happening in PCOS. But this is what maximum can be done.
Sir, if suppose if you give if your LH is and progesterone level is less than 3, LH15, you give after 8 hours the SCG dose 3000, correct?
Yes,
So
yes.
what will be the pickup time then?
36 hours. Very good question.
From there to 36 hours, correct?
Yes, absolutely.
Okay, sir. Thank you, sir. Thank you, sir.
The literature and lot of IVF consultants are also clear on this aspect, and they keep telling that you can do the pickup after 24 hours. No, you cannot.
Oh, 36 hours. Thank you, sir.
Yes. Yeah. Any other question?
So I have got one more question. If I want to do a FET, is it necessary to give Luprodex on 17 days? Instead of that, if I do E2 and progesterone LH level, and if it is less than 50, progesterone level is less than 0.5 and LH is less than 5. So can I go ahead with without giving Luprodex, sir? Without using Luprodex, I can start Istrabet and do the normal this thing, sir?
Very good question. So you mean to say, is down regulation is mandatory in HRT cycle? That's a question.
Yes, sir.
And disadvantage if we do not do?
Yes, sir.
Well, that is a question.
Yeah.
So one or two things to be kept in mind. That estrogen is weak suppressor of the FSH.
Yeah.
If you give estradiol, it will suppress the follicle. It will suppress the FSH, and by that it will suppress the recruitment of the follicle. But it is not always true. So if you want to be sure, and if you are not down regulating cycle, it is better to start estradiol on cycle day 1, not cycle day 3. You should start earliest. As soon as patient gets the menses, call the patient, examine, and start estradiol. That's one way. Now, most of the time there is no problem with this, but in 4 to 6% of the patient out of 100 patients, in spite of estradiol, there is a recruitment of the follicle. There is a recruitment of the follicle. After 7 days, if you call the patient, you will find a follicle which is in the range of 10 to 11 millimeter. Now, if you are not adequately knowing the reproductive endocrinology, you will be scared to see the follicle once you have started estradiol, and are not used to follicle once you start estradiol, because you will not expect. But nothing to worry. Don't keep watching the follicle and keep watching the endometrial proliferation. Somehow you have to reach cycle day 10 approximately. Now again you reach cycle day 10 and judge whether endometrium has crossed millimeter. If the endometrium has millimeter, means more than 8 millimeter or more than 8 millimeter, and if then look at the follicle. If the follicle is less than millimeter, without worrying, you can start progesterone, just neglect the follicle and go ahead as per the HRT cycle only. But the only thing, better do a serum progesterone level before starting progesterone. But if you do not have any facility to get the report of the progesterone immediately or within the same day, then you have to again see the texture of the endometrium. If the endometrium is classical triple line, then probably you may not go for serum progesterone. But in my experience and my policy, in HRT cycle, whenever I see a follicle, I always measure progesterone level. But if once the endometrium is crossed 7 to 8 millimeter, and if the follicle is more than 15 millimeter, then better to give SCG. No, why to avoid? convert it into a stimulated cycle. Consider it as a modified natural cycle.
But even after giving E2 right from the first day of the cycle, still we can give the beta trigger, correct, sir? In a
SCG, why not? Why not? It's very can be given. Consider that for all practical purpose, consider that cycle as a modified natural cycle.
okay, sir. There is something, sir, related with the natural cycle. Now, in a natural cycle, without giving,
Please
without
keep, please mute yourself. Please mute yourself.
sir,
Those who, yes, please,
in
Dr.
natural
Sandesh, please go ahead.
cycle, sir, in natural cycle, even if I don't give letrozole or anything in a natural cycle, the follicle reaches at around 18 to 20 millimeter. Endometrium is good. PI, uterine PI is good. Endometrial receptivity is good. Then I can give a SCG, correct, sir? Or I have to wait for the natural rupture, correct, sir? So if I give
If you,
SCG, if I give a SCG at 18 to 20 millimeter, so if I give it on Saturday, so Sunday morning or Sunday afternoon or night she ruptures. So when should I start the progesterone, sir?
a very good question. Okay. So you are planning to give SCG, always call the patient in the morning, do serum progesterone and LH level. If not both, at least do LH level. And always give trigger in the night for sure. So most of the time, by night time, the report of LH is available. If the LH level was more than 17 in the morning, then you should be more vigilant on next day for rupture. So you have to call the patient twice, morning as well as evening, next day morning as well as evening, and document whether rupture has happened or not. Now, if the LH level was less than 17, then you call the next day morning. Just to be on safer side, that the follicle has not ruptured. And if the second day the follicle has not ruptured, directly you call the patient third day evening. It will be perfectly 36 to 38 hours after your trigger. So at that time, if the follicle was ruptured, then my policy differs from many. I do not start. I do not. Please, Dr. Renu, please mute yourself. Dr. Renu, please mute yourself. Mute yourself. Dr. Renu, please mute yourself. So if the follicle has ruptured, my policy differs from. I am not in hurry to start progesterone because I perfectly understand that the follicle is ruptured. That means a lot of progesterone will be secreted from the corpus luteum in the early luteal phase. So I will start progesterone 72 hours after my trigger. 72 hours after my. That means 36 hours after the rupture. You can say roughly. I will start progesterone. Now, if the follicle has not been ruptured, it's not ruptured. That means adequate progesterone, even if has the progesterone there. So I want to start progesterone from that point of time. So suppose Sunday night I have given trigger, then from Tuesday evening, Tuesday morning I have given. So Tuesday morning, Tuesday morning I will start progesterone because I'm calling after 36 to 38 hours. From that time, I will start progesterone, and endometrial age will started counting from that point of time. But only to start progesterone in ruptured versus non-ruptured. It is differing in policy. Am I clear?
Yes, sir. But I don't know why the in a ruptured you're starting little late. Why 72 hours? That you can
Uh,
start it in that also, correct?
yeah,
36
see,
hours.
if the follicle is not ruptured, then don't wait more than 38 hours. After 38 hours, you should start progesterone.
Okay. And even if ruptured, then you wait for another 36 hours. That is your 0 day, correct, sir?
No, 0 days, 36 hours after my trigger is a 0 day.
Okay. So
I think
next day I can start.
progesterone is depending on whether follicle is
Okay, sir.
okay. Dr. Sabri, Sai Sabri.
Hello, sir. Good evening, sir.
Good evening.
Sir, when we are preparing endometrium while using estrogen, what is the minimum number of days that the estrogen can be given and the maximum
days.
number of days? Maximum,
Nine,
sir?
9 days, and is no. You can give up to 28 days also. You
Okay.
even little more than that also. That does not affect the implantation significantly. There are some studies. It says that after 17 to 18 days of exposure of estradiol, further, if you give more exposure to estradiol, marginally it reduces implantation. So in my practice, I don't give estradiol more than 17 to days because unless for some other reason, batching or something, otherwise by 17 days, even if the endometrium is thin and not adequate, it is less likely to improve by giving estrogen further.
Sir, like what is the minimum dose that can be given, sir? And what will happen that if you are using the dose like beyond that? Because in many centers, like I have heard the colleagues using like doses up to 32 milligram.
There is no point. See, always start with the even estrogen, you start with the lower dose, 2 milligram BD. So unless you are that, okay, this is the patient during stimulation also, see her endometrium has not behaved properly. In spite of such a high supraphysiological level of estradiol, the endometrium was not adequately proliferated during stimulation cycle also. So in such patient, I always start with the higher starting dose. That is 2
Sir,
morning,
sorry.
2 1 2.
Okay, sir.
Where I know already that this patient is likely to have endometrium because she has not given adequate endometrium during stimulation cycle. So I start with the high dose. Otherwise, in all other patients, lower dose, that BD.
Okay.
Start with the 2 milligram BD.
Sir,
And I always after 6 days. And after 6 days, I take whether to change the formulation or route of administration or simply increase the dose of estradiol or keep the dose same. Suppose at that point of time the endometrium is 6 millimeter, then I would continue with the 2 milligram BD dose only. Now, second question: if you give unnecessary higher estradiol dose, what happens? I will tell you the correctly answer and logic, which will you also will agree. What is the reason why we are preferring Efficacy cycle over stimulation cycle? For a simple reason, because we all know that it is not only a progesterone elevation, change of receptivity, but it is also a physiological level of estradiol, which is likely to affect the window of receptivity, which is likely to affect the villus differentiation, which is likely to the all perinatal problem of defective placentation. So we do not want all those problems, and that is the reason we are preferring frozen aminotransfer cycle where the estradiol level is ranging somewhere 200 to 800, not more than that. Okay.
Okay.
What happens? Suppose if you, like you said that in some of the center they are giving, I never given 16 milligram. That's my highest dose which I have given. Nowadays, even I don't use 16 milligram because I have started believing after results in couple of patients of thin endometrium, the to go by number and cancel if the endometrium is thin is foolishness, because the thin endometrium, the good euploid embryo uh, compensate for little thin endometrium, and if the endometrium is good, it can compensate for little bad embryo. So both are complement each other. Little bit whatever problems are there, they can accommodate each other problem, provided another is extremely good. So I do not go by absolute number to as far as the cancellation of the cycle is concerned. Of course, I need to counsel the patient for that. So what happens if you give a very high dose of estradiol? The action of the estradiol is not only to proliferate the endometrium, but it induces the progesterone receptor. So if you give a higher dose of estradiol, there is a more induction of progesterone receptor. So what happens with the smallest dose of progesterone, which normally, if you give vaginal, if you start with the vaginally, it will quickly reach the endometrium, and there will be an immediate massive transformation of that proliferative endometrium rapidly for into secretory, and likely to change the window of receptivity implantation, and which is going to give a implantation rate. That is my biggest concern. And second concern is obviously the abnormal placentation I want to avoid, because I do not want supraphysiological level of estradiol. Because if you measure serum estradiol level after such a high dose of estradiol administration, it is in the range of 2000, 2500, something like that. Because each estradiol tablet contribute approximately 40 picogram of estradiol. So you can count. Suppose if you use so many tablets, what will be the level of estradiol in the serum?
Okay, okay, sir. So we're like a poor response patient, you start with 2 in the morning and 2 in the night, sir.
And 1 in the afternoon.
Yes, sir. Yes, sir.
Sir,
So-
oh, sorry.
sir,
Okay.
I had one patient of previous 3 LSCS, sir. And all her previous 3 babies had skin problems and the babies died. And she has come for donor embryos, sir. And when I examined her, her cervix was unreachable, sir. Like it was so pulled and it was so high up. Like in such patients, like how can we plan for the embryo transfer in such patients, sir?
Under GA.
Okay, sir.
Under GA. Simple.
Sir, but when we fill up the bladder, we were not able to identify the cervix, sir. Like even if we do
No.
under...
No, what you do, you first catch the cervix.
Yes, sir.
Then don't call the patient with the full bladder.
Okay,
You
sir.
in the IVF OT transfer OT, you
Okay, sir.
insert the Foley's catheter or simple catheter and make it full with the normal saline
Okay,
according
sir.
to your requirement.
Okay, sir.
That's a standard practice in our unit. Our center.
Sir, for catching the cervix, you use Alice, sir?
No, ideally tinaculum should be used.
Tinaculum. But how long is it allowed, sir? Like, because if we catch the cervix...
Even
like...
because in a patient is under anesthesia, you should not worry, because it is not going to give pain, and so prostaglandin is not going to be released, and it is not going to initiate.
Okay, okay,
So
sir.
if the patient is under anesthesia, you should not worry.
Okay, sir.
Even
Okay.
without even this, I I had shown of Mrs. Mirge, where even if the patient was conscious, we injected lignocaine and we caught the cervix with the tenaculum and ET.
Okay,
Even
sir.
we did a little bit dilatation also,
Okay,
and we
sir.
did ET. There was some blood seen on the outer cavity. Still, he is having a positive cardiac activity.
Okay, sir. Okay, sir. And even if,
Okay.
what is the possibility of conception if we do, because many times I had one patient, sir, ET was only around 5.3, and I was advised by many to not do the embryo transfer when ET is 5.3. Like, if should we avoid during the doing the transfer in such patients, and should we go for alternate methods? Like, some people are suggesting to go for surrogacy in those patients.
Sorry, because you were not audible in between.
Sir, no, sir. Actually, like while preparing the endometrium, ET was only around 5.3 millimeters. So what many of my colleagues told was like, it is not better to do ET when endometrium is 5.3.
See, endometrium should be, if it is less than 6 millimeter, then it reduces the pregnancy rate dramatically. But if it
Okay,
is more
sir.
than 6 millimeter, some added Gcsf and PRP can help even if they do not increase the endometrial thickness.
Hello.
Yeah.
Sir, what should we do? Like if endometrium is only 5.3, if we do even in spite of all the
Uh,
measures we take.
before that, let me finish with this question, this gentleman, Dr. Ogunro, Ola Jumoke Ogunro. You can ask your question.
Good evening.
Good evening. Sorry, you are not audible. Lot of disturbance. No, madam. No. Hello.
Now.
Hello. You are
Hello,
not
can you hear
audible.
me?
No. Please speak again.
Okay. Okay, can you hear me now?
Oh no, a lot of disturbance is there.
Can you hear me?
Yeah, better.
Okay. Good evening, sir. Thank
Good
you for
evening.
all you do. I'm Dr.
Thank
Oguro from Nigeria. Okay, I
Yeah.
just wanted to know your experience about fluid in the endometrial cavity. Now I have a patient, she's now 42-year-old Nolipara. She actually did a donor cycle. The first cycle, she had fluid all through, and we drained a few hours before the embryo transfer, despite the fact that we did PRP and long antibiotic therapy. But she didn't get pregnant. So we reviewed her again. She had this intramural
You are not
fibroid,
the
which was
signals are.
removed, and then she also had her tubes. Came back when we scanned her, there was no.
You are not
Hello,
audible.
can you hear me?
Sir, you are not clearly audible. Please try to adjust mic or try to be in an area where a good this thing is there.
Okay, can you hear me now? Can you hear me now?
So you said
Can you hear me now?
that yeah.
Yes, okay.
You said
I have a patient with fluid in the endometrial cavity. She's had
okay.
2 cycles. The first cycle, she had persistent fluid. We drained and we transferred, and she didn't get pregnant. The second cycle, she had long antibiotic therapy. We clipped the tubes, treated the hydrosalpinx, removed the fibroid. She'd had hysteroscopy and we did adhesiolysis. But still, close to the time of the transfer, she had fluid. And this time around, even her endometrium was thick. So what else can we do apart from surrogacy? Because she has clipped her tubes, we've done adhesiolysis, but she just keeps having fluid.
So this is a persistent endometritis in the endometrial cavity. Now, this is more prevalent uh, especially in the presence of endometrial adhesions, intrauterine adhesions. If the intrauterine adhesions are taken care of proper, then this inflammation is going to reduce. No matter whatever amount of antibiotic you give, inflammation is not going to subside. So you have to redo histoscopy and do a thorough job as far as intrauterine pathology, whatever may, in the form of adhesions or whatever pre leftover adhesions, you have to take care of this adhesion properly. That is the first thing I would suggest. Second, there is some role of injection placentrex, which is available in India and which is used empirically for chronic PID cases. Some of the time, many times, even I have observed with the partially blocked tube or something like that. After giving this placentrex injection, maybe a day for 10 times, uh, there is sometimes a spontaneous conception pregnancy. So next thing which I would suggest is give some injection tracks. Third thing, please try to rule out the COX, the genital COX. Genital COX, I'm sure you know how to anticipate by looking at the endometrial cavity, pale endometrium, narrow endometrial cavity, some granulomatous endometrium is seen, and of course intrauterine adhesions are there. Endometrium is thin. There is a persistent fluid in the pouch of the glass. There is an increased vascularity in the uterus. So these are the signs of where you can anticipate genital cox. Even if genital cox are not strongly suspect in India because of the high prevalence of cox, sometimes we prefer to give empirical AKT in such type of the patient. So give AKT for 3 months. That's another thing. Fourth thing I would suggest, try to improvise the vaginal environment by giving a lot of prebiotic and probiotic for prolonged period. Give good antibiotic for at least 14 days, maybe clindamycin or will be preferred. And then after doing all this, you can attempt material preparation. And it is there. Necessarily, it should reduce the implantation. You can go ahead with the smaller amount of medium embryo. You can transfer the embryo, and nothing more can be done. I never advocate aspiration of the endometrial fluid. It never helps because you are aspirating is a the thing, the fluid which is going to be secreted in next couple of hours. So it is not going to help you. So these are the possible things which can be done. Otherwise, many times when you are using very high dose of estrogen, sometimes there is a fluid collection. And the moment you start progesterone, within 2 days, the fluid dries up. But I'm sure this is not a similar type of case. This is a purely endometrial collection because of the inflammation.
Thank you.
Thank you. Some who was asking, Dr. Sai, you wanted to ask. Dr. Sai, you were asking some other question. Yeah. Dr. Sai, are you there? If she's not there, Dr.
Hello, sir, I'm there, sir. Hello?
Yeah, please. Yes, please.
Sir, actually, what to do if, in spite of all the measures, if the ET comes around only 5.3 millimeters or 5 millimeters like that, sir?
So all whatever you can do for thin endometrium, one by one you can apply. The first thing to apply is to use a combination of Gcsf and PRP.
Okay, sir.
You start the cycle with the tamoxifen and letrozole combination along with the estradiol.
Okay.
Then use Gcsf and look for the vascularity and texture. If the endometrium reaches 6 millimeter and if it is a triple line and reasonable vascularity, you should not be hesitant in transferring the embryo. Suppose this fails, then next time you can try with intrauterine growth hormone uh, and Gcsf subcutaneous every 48 hours, couple of times, maybe 4 times, 5 times.
Okay.
And growth hormone injection intrauterine also on alternate. This, if you reach somewhere around 6 millimeter, you can transfer the embryos. Now, if this also does not work, then do histoscopy, rule out all intrauterine problems, check COX, rule out COX. If at all, if you think you empirical AKT, and if everything is done, still if you want to do something more, then do stimulated cycle. And sometime the natural estradiol helps in proliferation of the endometrium in a better way as compared to the artificial cycle. So this you can try. And all things which you already knowing. So you have to keep trying. And if this does not work, then one fine day you will sit with the patient and tell, okay, whatever happens, I'm going to transfer the embryo this time, and let's see what happens. And that cycle, do Gcsf, use Gcsf subcutaneous and do PRP at least 2 to 3 times, and then transfer the embryo, whatever endometrial thickness is there. Sometimes even if you will get the pregnancy in 5.5 millimeter also.
Sir, PRP, like you will give hysteroscopically in the previous cycle, sir?
PRP, I have stopped doing histoscopically. Sub-endometrial PRP, I have stopped doing because I did not find any positive effect, which is normally claimed by many. So unnecessary, it becomes more invasive, and I believe it is damaging sometimes because multiple punctures in the subendometrial zone. So I have stopped. Instead of that, even I'm happy with the subcutaneous repeated injection of GCSF.
Sir, can we use GCSF and PRP in the same cycle, sir? Can we give PRP intrauterine in the same cycle?
No. PRP intrauterine you can definitely give. Subendometrial you cannot. Intrauterine so you should.
In the same cycle of embryo transfer.
Absolutely.
Yes, sir.
Yeah.
Yes, sir. Yes, sir. Thank you, sir.
Okay. Dr. Nina.
Sir, I have one patient. She is having persistent fluid in the pouch of Douglas in spite of giving lot of antibiotics and pleasant drugs. So I have done laparoscopy, but I am not finding any Cox abdomen or any sign of tuberculosis. Still, I have started ATT. So my question is that after how many months I can transfer embryo, and should I continue ATT treatment after that also? After ET also I should continue it?
See, if you have started AKT empirically, normally I stop after 3 months if it is started empirically, because if any positive effect of empirical AKT is to be there is visible within 3 months.
No, sir. Should I continue ATT treatment after ET also?
No. 3 months. You stop after 3 months and then you start endometrial preparation.
Okay. Thank you, sir.
Yeah.
Sir, how should be given the letrozole and estrogen combination for endometrial preparation?
You can give letrozole. Uh, See, now that entirely depends whether you want to treat this cycle as a stimulated cycle or HRT cycle, because letrozole has got dual effect. It is used without cover of estradiol, it is going to recruit the follicle, and letrozole will have positive effect on the endometrium, plus the estrogen which is secreted from the developing follicle will proliferate the endometrium. But if you estradiol together with the letrozole, most of the time the follicle will get recruited, and you will here you are using estradiol letrozole only for its positive effect on endometrium.
So letrozole and estrogen are both given from second day of menstruation.
Can be given. Why not? Why not? Because here you are not you do not intend to develop the follicle. You intend to have effect of letrozole on endometrium by inhibiting the aromatase enzymes, and second by up regulating the certain integrins and genes which are responsible for the implantation, FOXA and this thing, integrins.
So if follicle comes with it also,
Sorry.
if follicle also comes with the letrozole estrogen combination,
Then consider, then treat it as a stimulated cycle.
Okay. Thank you.
If follicle doesn't come, then you treat it as an
HRT cycle. HRT cycle.
Okay.
Yeah.
Sir, do you look for a uterine artery PI in HRT cycle, sir? Before transfer,
if there is a thin endometrium, and or the vascularity of the endometrium after 6-7 millimeter, if the vascularity, if I find that vascularity, subendometrial vascularity is not good, so in that case, whether to judge, should I give more vasodilator or not? For that, I see a uterine PI. But now studies it should be less than 3.2. But now a lot of studies, they have proved that uterine PI does not predict anything. So better marker is directly seeing the subendometrial vascularity and endometrial proliferation and endometrial texture. Do not take any decision based on uterine PI.
Thank you, sir.
Thank you.
Sir, sometimes what happen, even after down regulation on very smallest dose, that is 2 milligram BD, on the 5th day we are getting near about 12 mm of endometrium. So is this good, or we can and on the 9th day it was 13.25 mm. So it is okay, and progesterone level is less.
Reach up to at least cycle day 8. Cycle day 8, minimum 8 days of exposure is required for estrogen. So by the time, if the endometrium is whatever, maybe 12 millimeter, maybe 14 millimeter, maybe 15 millimeter. See, immediately start progesterone and proceed for the transfer, because there is a study which says that if endometrium is more than 14 millimeter, it reduces the pregnancy rate. But then very recent study which has proved that really that does not happen. If the endometrial texture is good, and it is, even if it is 15 millimeter, the rate is same.
Okay, thank
Sir,
you.
in such patients, can we stimulate the cycle with clomiphene? And we can, in a patient of endometrial hyperplasia, where they go around 14 to 15 in around 10, 12 days only. So can we go through the clomiphene cycle in such patient, stimulate the with the clomiphene? It is anti-estrogenic, so it may not give you the more endometrial thickness.
See, somebody suggested this, but I am not convinced because the chloroquine not only acts as an anti-estrogenic, it affects the endometrium in another, like for example, VGF and other angiogenetic factors are less in clomiphene endometrium. So just for reduction of the endometrial growth, you cannot give clomiphene, according to my understanding. Rather than that, give smaller dose of estradiol, and within after 8 days, whatever good quality endometrium, whatever thickness is there, you can always start progesterone. And there is one more study, reliable study, which says that you should not put so much stress on the number thickness of the endometrium. Even they say, even you should not put so much stress on vascularity also. So it is a combination. I would say vascularity, thickness. There is a combination of three things. If one is not normal, other two things are other twos are normal, then you can definitely consider that as a good endometrium.
So in such patient, you start with estrogen with a very small dose, one tablet.
2 milligram. Start with the 2 milligram.
Only
Start with the
2
two
milligram.
milligram.
Okay.
Yes. See, I tell you, the lowest dose which can inhibit the pituitary is 2 milligram of the estradiol.
Okay, sir. Thank you, sir.
Sir, is it possible that endometrium to reach 13 mm and zonal vascularity is 2?
This really still sick. I keep trying vascularity in all patients of embryo transfer. I have never seen any endometrium which has become 7 to 8 millimeter triple line, and still the vascularity is inadequate. It is not never possible. I don't know from where this concept has come, when the endometrium is adequately proliferated. Because
Yes, sir.
endometrium is adequately proliferated, that means the estrogen has reached the end organ site.
Yes, sir.
And so there is no point in vascularity, measuring vascularity, if the
Okay,
endometrium is
sir.
adequately proliferated.
Okay, sir.
Sir,
Sir,
when we give letrozole and estrogen together, how many days we can give letrozole in this case?
Letrozole and tamoxifen, you mean to say?
Letrozole and estrogen.
Okay. Give letrozole for 5 days only.
Okay.
Sir,
And tamoxifen for how many days should be given?
Tamoxifen also 5 days.
So to reduce the progesterone level on the day of trigger, you suggested to drop the dose of the gonadotropins for the last 2 days. So I want to know when to actually drop the dose if supposedly the antral follicle count is around 8 and around 4 to 5 follicles are of 15 mm, but the 3 to 4 follicles are
Now
of
you only will answer. The basic understanding is the follicles keep growing even if you stop gonadotropin for next 4 days. And estradiol keep increasing for next 4 days even if you stop gonadotropin. So what is important? Both are important for us.
Mhm.
So last 2 days, definitely without any worry, you can half the dose or give a minimum gonadotropin of 75, because you have down regulated the cycle. So this rule of natural these rules are of down regulated cycle, and you have down regulated or with GnRH analog, either antagonist or agonist. At least some gonadotropin you have to give, minimum dose of gonadotropin you have to give. So you can afford to reduce to 75 to 150 last 2 to 3 days. Sure.
will it affect the growth? Like suppose there are
Absolutely not.
three to
Absolutely
four.
not.
No, sir, I have a
Absolutely not.
basic confusion. Like if there are supposedly 3 to 4 follicles of 13 which we are trying to recruit in the at the time of trigger. So if we give gonadotropins for another 2 days, so we hope to reach them till 15 to 16 mm. But
Say,
if
I
we
said first, what was my first sentence? First statement was the follicle keep growing even if you stop gonadotropin for next 4 days. Because steady level is only after 4 days of gonadotropin. And that gonadotropin keep that follicle growing.
okay, right, sir.
So
Thank you.
here you whatever gonadotropin you are in, because this is a cycle. So control hyperstimulated cycle, all the follicles are of not same cohort. So there is maybe some asynchrony. So to take care of that asynchrony, you are totally bombarding with the higher dose of gonadotropin, right?
Right,
But
sir.
in the last 2 to 3 days, if you still continue with the same dose, you are increasing a follicle which are approximately 10 millimeter of 10 to 12 millimeter size. They are not going to a mature oocyte, but they are going to add estradiol. They are going to add progesterone. So if you are intending to transfer fresh, that will create a great hurdle, and that's the reason if you want to avoid a progesterone elevation and if you want to transfer fresh, last 2 days you should reduce the dose of gonadotropin. And
And sir,
that is the rest. This idea came when they tried compare with the choreotropin alpha, which is slower acting. Once in a 7 days, you have to repeat the dose. So what they observed that if you are using this choreotropin alpha injection, you give on cycle starting of the cycle, and then repeat in the mid cycle 6 7 days. So what they observed that you first injection, the which is is less at the end of the cycle, the 7 day cycle, and because of this of progesterone expression was much more as compared to the daily RFSH administration. So from that study, the idea of reduction of dose came.
okay. And sir, supposing if we are not planning a fresh transfer, to still does it affect the quality of the follicle? If it is necessary to drop down the
No,
dose,
it's a healthy way. I would say it's a healthy way.
we
It's a
should be
healthy way of stimulation. Yes, healthy way.
irrespective of if even if you are planning the FET, we should be
Yeah,
dropping down the dose in the last 2 days.
absolutely, absolutely. Because ultimately, even in FET, if the progesterone elevation is too much, maybe 2.25 or something like that, the embryos which are formed out of this oocytes are not giving adequate pregnancy rate. So it is not like that you intend to freeze all. That means you can give any amount of gonadotropin. No, you cannot.
Okay. And sir, we should be starting the stimulation only when the antral follicle are more than 4 mm. Like sir, I had one case where I had given an ultra long agonist, and the third agonist had not worked, and there was a premature recruitment of about 10 mm on the day of start of 14 days after the last dose of agonist. And then I started OC pills, and after 12 days of OC pills, when after 5 days of washout period of OC pills, when I again saw the patient, so she had follicle barely 1 to 2 mm. So I should have waited for one more day or 2 days. Do you say so?
Yeah, but because it is see, if you do not find adequate number of the follicle, enteral follicle, maybe because of the prolonged downregulation of agonist followed, then you can always start after 5 days of washout. You can keep watching the patient every second day, and when you find a adequate number of cohort, then and then you can start simulation.
And so one more query, sir. In which cases do we need to start
This is
over?
last time because I have to go.
Right.
30.
In which cases do we need to start LH from the beginning? I mean, in elderly patient and
Elderly patient, proceed on group 1, 2, 4. Simple. You remember 1, 2, 4.
Okay. Right, sir. Thank you, sir.
Okay? Thank you.
Thank you
Chalo,
very
bye
much,
bye.
sir.
I take a leave. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you.